My name is Dr. James Case, and I'm the Chief Scientific Officer at CVIT. This educational video will review how to use the quality assessment features of the ImagenQ and ImagenQ MD software packages. These indicators and tools can be essential for identifying problems with the dynamic rubidium PET study. These tools, however, should not be used as a substitute for understanding how blood flow is determined or a physician's clinical judgment. The quality control features within the ImagenQ software package help the user identify the region of interest that is going to be used, as well as the location of the blood pool ROI. On the far left of the ImagenQ screen, we can see the short axis, horizontal, and vertical long axis slices. Surrounding these is the myocardial boundary. When bringing up a study, the technologist should review the accuracy of these boundaries to ensure that the myocardium has been correctly outlined and that no non-cardiac activity is included within these boundaries. The second set of images within the center represent the location of the blood pool ROA, indicated here as a square within the image. To change that location of the blood pool ROI, we click on the Reposition Roi, locate the center of the blood pool ROI, confirm it on the short axis, which is the left image, and the vertical long axis images, which is the far right, and then hit OK. If we want to make fine adjustments, we can shift these back and forth with these arrow buttons. Similarly, we can do this with the rest. Move the image, do any fine adjustments that we want to do, and then hit OK. Then finally, to help us with the quality assessment, we come to the final panel, which includes assessments for the background, the peak to plateau, the peak time, and the noise. I'm going to go over in detail what each one of these represent. The first of which is the background counts, and that's the number of counts that are seen in the very first frame of the image. And let's back up to these. And as we can see, at stress and rest, there are no counts in the background. And we can also see these within the arterial input function on the bottom. There are no counts at the very beginning of the study. This is important that we have no counts at the beginning of the study, as we want to capture the entire blood pool input curve as it passes through the ventricle, out through the aorta, and into the myocardium. So we want to capture that bolus all the way through. The second number that we identify is the peak to plateau. That is the ratio of the maximum counts within the blood pool divided by the equilibrium out here at 150 seconds. We would expect these to be greater than 6, but they need to be greater than at least 4. Any time that these might get lower may indicate some problem with the location of the blood pool ROI or the generator. There can be occasions at the end of the generator life that these numbers might slip below the factor of 6 that we are hoping to see. This may not necessarily negate the value of blood pool imaging, but it can cause a reduction in accuracy. The peak time, we want the peak value, as we can see here in red, on the red curve and in the green curve, to occur between 25 seconds and 75 seconds. Then lastly, the noise in the image is the amount of noise in the final frame of the dynamic image, and we want these to be less than 0.25, and that number is the ratio of the mean variations within the ROI divided by the mean value. So for this study, we can do our quality assessment as follows. First, we review the blood pool ROI, the myocardial ROI, and then we review the location of the blood pool ROI in all 3 directions. And then we look at the arterial input function, verifying that it reaches a sharp peak and empties, whereas the myocardial ROIs, the blue and the yellow, reach a constant value, typically greater than the final blood pool value. And then we can look at our indicator lights, verifying that the background had few or no counts within it, the peak to plateau is greater than 6, the peak time is between 25 and 75 seconds, and lastly, that the noise is less than 0.25. This would indicate that this is a high quality study, and we should be able to accept the quantitative values we obtain. By clicking Show Results, we can see that this is a completely normal study with 2.22 ml per gram per minute at stress, 0.77 ml per gram per minute at rest, and a flow reserve of 2.89. And we can have confidence that this study, acquired on a GE NXI system, is of high quality and the blood flow numbers can be trusted. The next example we're going to look at is a situation where the infusion system was started prior to the start of the acquisition. This has the problem that we do not capture the entire input function of the activity, causing us to underestimate the activity in the blood pool or in the arterial input function. We can see that our lights that we would typically rely on show a background value of 0.41 and a stress peak time of 7 seconds. We can see this also in the arterial input function. So what has happened is we started the acquisition while there were counts already in the image. We can see that also here by backing up the time frames. We can see at the first time frame at 7 seconds there's already activity within the blood pool ROI. Now what this has the effect of doing is reducing our estimate of the blood pool. And when we underestimate the blood pool values, we overestimate the blood flow values. The two work in opposition to one another. So when we look at our final result, that appears to be a normal study with 1.97 ml per gram per minute, resting flow of 0.66 ml per gram per minute, and a flow reserve of 2.99, these numbers should not be trusted because we can't be sure that we captured the entire input bolus. And because we did not capture the entire input bolus, these numbers, the stress flow numbers, might be overestimated and masking a possible defect within the image. That doesn't mean that we have compromised the quality of the perfusion and gating study, just the flow study. So in this case, all the interpretation would have to take place in the absence of the flow data. The next example that we will look at is an example of a patient with extensive ischemia. So in reviewing the quality of this image, we can see right at the very beginning we have 2 red lights and 2 yellow lights, indicating the possibility of quality control problems with this study. As we dig into understanding the source of these red lights and yellow lights, we start by examining the myocardial ROIs on the far left, and we can see at both stress and at rest the myocardial boundaries do trace the myocardium well. So these are not the sources of these unusual measurements within the quality assessment tools. The next thing, the peak to plateau, which again is the ratio of the peak activity in the blood pool to its equilibrium value at 2.5 minutes. We want to confirm when we see these lights that we have identified the blood pool ROI well. And as you can see in this frame here, we can see the blood pool very nicely separated by the septal wall in the right and the left heart, and our left atrium very well visualized behind the left ventricle. And again, in the short axis view and the vertical long axis view, this location of the left atrium is very good. Again, we'll confirm it at rest. Get a good view of the blood pool. Maybe move it up just a touch. So at this point, what we have is we have one red light for the peak to plateau, one red light for the noise, and one yellow light for the rest. We have confirmed that we've positioned about as well as we can the left atrium at stress. However, it has not caused this to be a sharp enough peak to make this light yellow or green. This patient has extensive ischemia and had a drop in ejection fraction at stress, and indicating a poor ventricular clearance of the activity may be the source of this less than sharp peak at stress. So in this instance, this red light has nothing to do with the quality of the study, rather the functional state of the patient. So we can discount this red light as being a result of the patient's ischemia. And now we look at the stress numbers, and the stress has a high noise value of 0.41. The software cannot distinguish between noise, variations in counts due to coronary disease, or variation in counts due to the noise in the image. That's why when we are investigating the sources of these lights, we have to understand what's going on. And in this case, these variations are a result of true variations in uptake. And we can discount then this red light at stress as being the result of true variations in rubidium uptake. Now the yellow light at rest looks like there is some noise at rest, and maybe a mixture of the patient's ischemia and injury, as well as some lesser uptake. So probably this yellow light is probably somewhat correct, that we're not ideal in terms of our counts, and it would be nice if it was better. When we see these yellow and red lights in the noise, we tend to put less emphasis on regional variations on the flow values. So in looking at this study, finally, we have good background. So we captured the entire blood pool bolus. We have a stress peak to plateau, which is less than we would expect, probably due to the poor ventricular function, due to the effects of the vasodilator. A good peak to plateau at rest, good timing of the boluses, and noise values at stress, which are probably due to the real ischemia, and a less than ideal resting noise values, probably as a result of poor counts. So finally, when we look at the study, we see that this patient has extensive 3-vessel disease, and probably the worst of which is in the territory of the left circumflex and also in the right coronary artery. The final example that we're going to look at is a case of a patient with a cardiomyopathy and a large BMI. So in this example, we look at our quality indicators, and we have 3 red lights. A red light for the peak to plateau at stress, and then the noise at stress and rest. So we begin our quality assessment by first looking at our myocardial boundaries, which do seem to track the myocardium well. The second part of our quality assessment will be to verify that we have selected a good blood pool ROI. So we can scroll through the images, make sure we have a good view of that left atrium, maybe there. See if that's better. So the stress looks much better now. Rest looks very good too. So we've moved the peak to plateau from the red to a yellow. Peak time is good. Then we get finally down to these noise values. And as you can see in the final frames of the dynamic study, the myocardium is very poorly traced and very noisy. So these noise indicator lights would be correct in saying that there is a high amount of noise within these images. So when we go to interpret these results, we generally can assess these in terms of the blood flow values, global blood flow values. So the 0.65 and 0.54 are probably okay. However, these individual territories should be discounted because the variations within the myocardium are going to outweigh are going to be outweighed by the noise in the images. So within this study, we're looking at a patient with a severe cardiomyopathy, extensive coronary disease, and very poor vasodilatation as a result of the vasodilator. So in conclusion, when using the quality assessment tools within ImagenQ, it is essential to remember that these quality assessment tools help to identify when a dynamic study may be inadequate and potentially result in inaccurate flow and flow reserve numbers. The quality control lights should be used as guides as to where to investigate possible shortcomings in the dynamic data quality, but should not be used as go, no-go type of decision-making tools, as in many cases we may find a study that has a red light might be a result of true variations within the patient, a result of the patient's ischemia, or may not negate the entire study, maybe just portions of it. So when looking at those indicator lights, it's essential that it draw attention to potential problems but not be used as a go, no-go type of decision-making tool. So to request more information or to schedule a training session, please feel free to contact Stacy Corder. Email is on the screen right there or at the phone number listed there. And to learn more information about our other products, please visit our website at www.cvit.com.